I think everybody's here now, so Emily's going to talk to us about chronic liver disease on ITU.
Hi guys, so this is quite a huge topic. I'll just try and make a summary out of it. I've tried making a summary out of it. I hope it's good enough summary. So mostly what we're going to be looking at is acute and chronic liver failure, because that is what we are faced with in the ICU. Yeah, so my name is Emily. I'm ITU fellow. I'm in Leicester Royal Infirmary. So what is acute and chronic liver failure? There are many definitions that have been used to define it. One of them is by the Asia Pacific, which came up with as acute hepatic insult, manifesting as jaundice and coagulopathy. It's complicated within 4 weeks by ascites and or encephalopathy. So that is one of them. So it's a patient who comes in known to have a cirrhosis. They come in with jaundice, encephalopathy, ascites, bleeding. Then you should suspect acute and chronic liver failure. What are the causative factors? What we will be looking at is the causative factor, the precipitating event, and it's also associated with failure of one or more organisms or organs. Sorry, it's a multisystemic disease. It has quite a high mortality of 50 to 90%. Yes, we'll look at the pathophysiology later. So what's the epidemiology? There's not much data on the epidemiology in the UK, really. The data that I came across was from the US, where the mortality was found to be about 53% in the patients who were admitted in the ICU, in the hospital specifically, and with a hospital stay of about 17 days. So what we know is that transition from compensated asymptomatic cirrhosis to decompensated cirrhosis is about 5 to 7% per year. What is the pathophysiology? The common causes that we see here are alcohol, NASH, HCV. That's where it's becoming quite common. This is the growth area and the one of the commonest causes. Looking at the precipitating event, we need to look at it's either could be liver or extra hepatic. One of the commonest causes, which is extrahepatic, is sepsis. So any patient who presents to you with acute and chronic liver failure, one of the things that you need to think about is there an infection going on, apart from the obvious ones who come in with GI bleed and alcohol hepatitis. So that is the other common cause. So looking at the precipitating event for the liver causes, alcohol hepatitis, which is quite common. Drug-induced liver injuries. It could be viral hepatitis. Any patient who presents to you, you need to think of HB virus, HCV, hepatitis E virus. You need to remember that there are patients who come in from the Asian countries, from African countries where hepatitis E is prevalent. So think of doing such tests, and it has a poor prognosis. It could be a reactivation of an underlying hepatitis B or C virus or E virus. Other precipitating factors could be portal vein thrombosis, ischemic hepatitis, hepatocellular carcinoma. Stop me if you need to ask any questions. So the extrahepatic causes are trauma, surgery, and I said acute variceal bleeding, and some of the patients do not have any known causative factor. There's also hepatitis A virus, which you need to also think about. You need to also think of doing such tests as well. Okay. So what is it's a busy slide, but the summary here is cirrhosis is a chronic inflammatory disease. multisystemic disease. And what happens is with continued liver injury, patient develops cirrhosis, portal hypertension. The portal hypertension results in increased gut bacterial translocation from the gut. So with the increased bacterial translocation from the gut, we have the bacteria and the bacterial products, which I have indicated there as PA and PS, which is pathogen-associated molecular patterns. All these contribute to the inflammatory process. So what they do, they bind to the immune, the receptor cells, receptors of the immune cells, and they will activate the innate immune system. And the activation of the innate immune system, it results in release of pro-inflammatory cytokines and chemokines, and therefore release of reactive oxygen species and reactive nitrogen species. And that's when you say that these patients usually have increased nitric oxide, prostacyclin, endocannabinoids. All this will result in vasodilation, and the vasodilation is mostly in the splanchnic bed. And that's how they come in with a hyperdynamic circulation. The cytokines as well cause cardiovascular dysfunction because it causes inflammation to the myocardium. We also have the liver injury releasing the danger-associated molecular patterns, which also activates the innate immune system. And with this vasodilation, widespread vasodilation results in a reduced effective hypovolemia. So we have poor oxygenation at the tissue level. The organ that is mostly affected is the kidney. This vasodilation is responsible for the hepatic encephalopathy, for the hepatopulmonary syndrome, and the adrenal dysfunction that is seen in acute chronic liver failure. So we go to the management of these patients and organ support. When you receive a patient with cirrhosis, what are you thinking of when you're reviewing them and in the management? What is your aim of treatment? You need to think of what is the cause of this liver failure. What is the precipitant factor? What are the organs that are involved, and how would you want to support them? The investigations that you would want to do, and also you need to prognosticate them. There are many. If patients in the ward, we receive patients in ICU who have already decompensated. So ideally, in an ideal situation, you would want to suppress the etiological factor, like stop alcohol intake, treat the HBV and HCV. But even with that, not all patients respond. They don't recompensate or regression of their cirrhosis. Even once all that is treated, some patients end up still progressing to decompensated cirrhosis or acute and chronic liver failure. Other things that you can do is target the pathogenic events. So you will find some patients coming in with rifaximin, and these are treatments that are not yet good evidence. There's not much evidence on them, but some centers use them. Use of rifaximin to avoid to manage the bacterial translocation from the gut. Other centers have used norfloxacin, but that has it's no longer popular because it's associated with antibiotic resistance. Other things that have been tried are statins to reduce the inflammatory reaction, or non-selective beta blockers have also been used to reduce portal hypertension. That we know is being used for the patients who are not critically ill in the ICU. So when you review the patient, the first thing you want to do is ABC. You want to ABC, clear the airway for that patient who is hepatic encephalopathy, drowsy, risk of aspiration. The investigations here, as I said, hepatitis A, B, and E. E has quite poor prognosis. You want to look for other tests depending on your suspicion, CMV, HSV, PCR, fungal biomarkers, which we usually do, beta-D-glucan. If you're suspecting HCC, you want to do alpha-fetoprotein. You need to get the drug history of the patient, remove the iatrogenic drug because that will be a causative factor, and acetic tap. For any patients who come in with cirrhosis, with ascites, you want to do an acetic tap to rule out SBP. The prognosis of SBP has become much better, from 90 to 20% because of early diagnosis with early acetic test to rule out SBP. Once it's diagnosed early and it's treated early, it's a better outcome. You could do liver biopsy. Then for any patients who come in, one of the key tests that you want to do is an ultrasound of the liver. Look at the vessels, rule out portal vein thrombosis. You want to do an echo. Remember, they come in with cardiac cirrhotic cardiomyopathy. Or you can even do a CT head for patient who comes in with encephalopathy. Okay, so we look at support each system, how you support it. So cardiovascular, as I said, we have looked at the pathophysiology and have seen how arterial vasodilation occurs, resulting in hypovolemia. Reduced effective hypovolemia, sorry. So that is one thing, they have a hyperdynamic circulation. The other thing is that they have cirrhotic cardiomyopathy due to the inflammatory cytokines, which also which results in that. So for cirrhotic cardiomyopathy, this is usually masked by the hyperdynamic state. But once this patient is exposed to some stress of some form, surgery, or if it's due to sepsis, the systolic function is poor and the diastolic function is poor. So they will not be able to mount a good cardiac response in the case of stress. And they have LV failure. What are the tests you want to do for this patient? Any patients who come in with cirrhosis, you need to do an echo. Try and get the baseline function. You want to consider things, usually volume status. So they will come hypovolemic due to various reasons. And this could be because they have been on aggressive diuretic therapy, just because they have just been unwell, because of the sepsis. You need to monitor the volume state, and your volume replacement should be guided in order to avoid hypervolemia, which also has the deleterious effect. There's a dynamic measurement. We use a PA catheter. You can use a PA catheter. Dynamic assessment is said to be much, it's better than the static. However, we usually use static. The static will just guide if there's some response to the fluid therapy you're giving. If you feel that the patient has, you've achieved a good fluid volume, then the next thing to consider will be vasopressors or ionotrope, depending on what you find on your echo. Yeah. So the noradrenaline can be used. There's noradrenaline, talipressine. Noradrenaline has to be given in ICU. Talipressine can be used in the wards as well. And the inotropes could be Mirena and dobutamine. So there's a role of albumin. Albumin is also associated in these patients, especially in the patients who have some form of hypovolemia affecting the renal function. this is thought to be quite effective in preventing development of hepatorenal syndrome together with vasopressors. So it's, yeah, it can be considered when you're volume resuscitating your patient. What about beta blockade? A systematic review suggested that beta blocker exposure prior to an episode of sepsis could have a role in reducing mortality. However, our patients, when we see them, they're quite unwell, they're cardiovascularly unstable. Those are not patients that you want to start beta blockers. It needs to be based on individual basis. Yeah. Respiratory support. The respiratory support here, the common complications are pneumonia, hepatopulmonary syndrome, portopulmonary hypertension, and hepatic hydrothorax. So these patients usually are immunosuppressed. They're at high risk of pneumonia. Hepatopulmonary syndrome is still the same pathophysiology of increased nitric oxide. Do I have a pointer? So there's increased nitric oxide that causes vasodilation, and also it's also associated with AV malformations at the pleura and the pulmonary, and this will result in a VQ mismatch and shunting. So if you look at this diagram here, you'll see that this is the effect of the nitric oxide, and the PaO2 still remains the same, but the amount of blood passing through that capillary is quite dilated, and the amount of blood that is passing through that capillary, the volume is quite huge. Not all that blood will end up getting oxygenated, and that's how hypovolemia results. So these patients they'll also have the AV malformations that also results in the shunts. They will present with, when you sit them up, they become more dyspneic, hypoxic, and when you put them to lie down, they become, you see, they get better, and that's what we call the platypnea. Portopulmonary hypertension usually has a poor outcome, and it's one of the contraindications to liver transplant. So for patients who have mean pulmonary arterial pressure of more than 35, are usually, the plan will be either to try and reduce, and if the pressures remain that high, they're usually not taken for liver transplant. If you have a patient who has got pulmonary hypertension, drugs that you can use are bosentan, the endothelin receptor antagonist, and prostacyclin analogs like icoprostenol, or nitric oxide, phosphodiesterase inhibitor, whichever you choose. And right ventricular support. However, for those patients who have quite high pressures, they don't have good prognosis. So renal support for these patients. So there's hepatorenal syndrome, and there's the non-HRS AKI. When you receive a patient with liver failure, just remember that HRS, pure HRS, is uncommon. Think about all the other factors that could be causing this renal failure. It could be so that's non-HRS. We need to think of any renal insults. It could be hypovolemia, sepsis. It could be drugs, drug-induced tubular injuries. Some of them have been really diuresed until they're hypovolemic. Think of such things. If it's HRS usually, what you say, it's just the same pathophysiology as we've been speaking about. The ineffective volemia due to the widespread vasodilation, and the effect of the pathogen-associated molecular patterns and the danger-associated molecular patterns, which also bind to the tubular cells and activate the innate immunity, and this results in renal failure. Usually, sometimes the HRS and the non-HRS would overlap. So remember that it's uncommon for HRS AKI to just have a pure HRS AKI. So how do you approach these patients? Initially, you want to ensure that their volume is replaced, that the patient becomes volemic. You want to remove the precipitant factor. If it's you need to stop the diuretics, any NSAIDs that the patient has been, ACE inhibitors, then you need to also assess the intra-abdominal pressure. They could be having tense ascites and they need a large volume paracentesis. That sometimes help improve their renal function. Next thing you need to think of is talipressine and albumin. So you can do talipressine alone, but a meta-analysis that was done showed that there's better outcome when you use talipressine and albumin. Why? Because albumin improves the volume, and when you're giving talipressine, it will tend to decrease the cardiac output due to the vasoconstrictive effect. So albumin has improved the volume. Also, it has anti-inflammatory and antioxidant effect, and that's the reason why albumin is used with the talipressine. However, it can be used alone. Think of noradrenaline and think of renal replacement therapy. Patients who require renal replacement therapy and they have HRS AKI they do not have good outcome, because the main treatment for HRS AKI is liver transplant. So the other treatment will be liver transplant. There are biomarkers that have been used to try and differentiate between HRS and non-HRS AKI. And one of them is the neutrophil gelatinase associated lipocalcin, what they call NGAL. That is used to identify if patients have ATM, but those are just details for another day. So what's the neurological support? So most of the patients come in with hepatic encephalopathy. The commonest cause is hepatic encephalopathy, but remember that these patients are at risk of other neurological complications, and that includes intracranial hemorrhage. We just admitted that patient the other day thinking that it was just hepatic encephalopathy, to find that he had intracranial hemorrhage, which is a learning point. Drugs, electrolyte abnormalities. Remember that these patients come in with issues with hyponatremia, and hyponatremia is associated with poor prognosis. Infections and metabolic imbalances. Patients with acute and chronic liver failure are at lower risk of brain swelling compared to the acute liver failure. So what investigations do you want to do for these patients? You want to take an ammonia level and do a CT head. Treatment, treat the cause. If it's infection, treat the infection. If it's hyponatremia, you need to correct the sodium. At least get to a sodium of 135 and above. Treat the bleeding, because it could be due to acute variceal hemorrhage. Acute variceal hemorrhage usually will result to an increased portal hypertension that will result in a vicious cycle. Intubate and ventilate, as we said before. For the ammonia, you want to consider lactulose. You want to consider ammonia lowering intervention. One of the reasons to go on renal replacement therapy, especially for those patients who are for liver transplant, and with probably good outcome, depending on the prognosis, you would want to think of early renal replacement therapy for such patients. Feeding, you need to start enteral feeding. Rifaximin, as we said before, Rifaximin helps in lowering the ammonia levels, and it also helps in managing the bacterial translocation. You have the liver support like tips, and the other thing is time. You need to give them time to recover. Avoid benzodiazepines. So GIT and metabolic support. The GIT and metabolic, mostly our issue here is ascites. It is acute variceal hemorrhage, hyponatremia, glycemic control. So any patients who come in with ascites, as we said, intra-abdominal pressure, take the intra-abdominal pressures. They will benefit with large volume paracentesis. And you need to be careful when you're doing paracentesis because this patient can develop post-paracentesis cardiovascular dysfunction. And therefore, for every 5 liters of ascites, if you know you're going to remove more than 5 liters of ascites, cytic fluid, then albumin of 8 grams per liter of ascites removed should be given. What is the other thing? Yes, and diuretics. You want to start with an antimineral or corticoid. Why? Because due to the vasodilation, we have the RAS system which is activated. With an increased aldosterone, will increase sodium absorption. And this sodium absorption and water absorption is the main contributor of the ascites. So you want to start with spironolactone. Consider furosemide as well if they're not responding to spironolactone alone, because furosemide will help in excretion of the sodium as a loop diuretic. Also, non-selective beta blockers like propranolol have effect because they reduce the portal hypertension. Consider tips. Role of PPI. PPI, not all patients need to go on PPI unless you think that they have gastritis. However, it's recommended that you can use a PPI after band ligation because of the ulcers associated with it. This is a short term. Acute variceal hemorrhage. How do you manage it? It's the ABC as discussed. The first thing you want to do when you get a patient who has acute variceal hemorrhage, give talipressine, somatostatin, or octreotide. Give antibiotic prophylaxis. Then, if patient goes for therapy, it means that the risk of bleeding once the talipressine has been given is less. You need to maintain the talipressine. Usually we do 2 milligrams 4 hourly for about 48 hours. Then go down to 1 milligram 4 hourly, which can go up to the total of talipressine should be just 5. It can be only 5 days. If the patient is bleeding, then consider tips. If the patient has come in with massive hemorrhage, other things that can be employed are balloon tamponade or esophageal stenting. Okay. Sepsis management. Mostly these patients come in with issues with sepsis because of bacterial translocation, portal hypertension with increased gut permeability, bacteria and bacterial products, and also poor peristalsis that results in bacterial gut overgrowth. Our main issues is the spontaneous bacterial peritonitis. So for such patients, you want to do an acidic tap. If the neutrophil is more than 250, then start treating. The antibiotic treatment depends on the hospital policy. It depends on whether it's community acquired. It depends on whether it's health associated. The cultures are not, the treatment is not dependent on cultures, it's dependent on the neutrophils. So even if the patient comes in and the cultures are negative, they still need to be treated as SPP. How do you treat? Antibiotics, as I said, Remember albumin, as we have discussed earlier on, that it will also, SBP is associated, it's associated with hepatorenal syndrome. Think of giving also albumin in patients who come with SBP. Okay. Coagulation support, this is a very busy slide. What summary here is that there are many other factors that are not considered when we do standard lab tests for coagulation. That is antithrombin 3, protein C, and S, which are also low. So it is reduction in both pro-anticoagulant and anticoagulant factors. So these patients might look quite coagulopathic, but they don't bleed that. Doesn't mean that they bleed that easily. Might have thrombocytopenia, but the von Willebrand factor is quite high. So the thrombin generation remains okay. So the best, when you speak to this patient, sometimes a TEG would give a better information on the patient's coagulation status. So think about it, TEG, if to guide a blood and blood product administration. We give vitamin K. As we say, that DVT prophylaxis should be considered because they are not in increased risk of bleeding. What's the prognosis? There are very many scores that are being used in prognosis here. There's a MEL score, and now the MEL sodium score, because hyponatremia has been associated with poor prognosis, so sodium has been added to that. This Child-Pugh score, and there are others like SOFA score. The Cliff SOFA is just a modification of the SOFA in cirrhosis. And then there is acute liver failure, grades 1 to 3. As you can see, that is the table here shows the grades of acute liver failure. So the 28-day mortality with acute liver failure grade 3 is about 78%. So that is the organ failure SOFA score. Yeah. All these scores should just be used on an individual basis. You'll find that there are many patients who score really well, especially when they're in the critical state. But that does not mean that they should not have a liver transplant. You should be looking at other factors. So it's based on individual by individual basis. You should be looking at the age of the patient, the comorbidities of the patient, and also even if they are they might be having a good score, but they are not fit for surgery. So there are many things to look at. And that's just a summary of the transplant. As you can see, in the UK, patients who came with more than 3 plus organ failure, who would be acute liver failure grade 3, their 1-year patient survival was 90%. So it's the scores should not determine fertility. And I guess that's the end. I'm finished. Any questions?
Thanks, Emily. Anyone in the room got any questions? Not?
It was quite long.
Well, about right. They're a very difficult group of patients to decide to admit in the first place.
Yeah.
It's always a bit of a heart sink moment when we get a referral from ward 42 or 43.
Yeah.
How do you reckon you decide to admit them in the first place?
So what I can say is decision to, I mean, most of the time, actually, they have been seen by the hepatologist, and some of them already the hepatologist has decided this is futile. For the patients, those ones we don't consider. Then we have the patient who comes in. It depends on what they have, what the cause is, what their baseline has been all this time. So there are many factors that we'll be considering. What's their functional baseline? Are they patients who've been unwell for years and years, and this is just it's a progressive disease? No liver transplant is going to happen here. Then if ICU is that point, you can say ICU might be futile. And there's a patient who comes in, it's just a short history of that acute decompensation, apparently fit and well. And they have now multi-organ failure, either they're hepatic encephalopathy that need airway support or cardiovascular support. Those ones we take. Others we take with a limitation of care, maybe plan to just cardiovascular support and renal support. And others come in because they pass through or the OR after variceal bleed, and they come in intubated, and we have not, we take them to just eventually wake them up and discharge.
Yeah, that seems to happen most weeks. Well, it always used to. I assume it hasn't changed a huge amount, but
yeah, it's not. It won't change in years to come.
Anybody else got any questions?
Okay.
Thank you, Emily.
Yeah.
So Joe's going to do our journal club on. Are you doing the recovery trial? That we've all been recruiting to for the last 2 years with all of our COVID patients, basically. So that should be interesting to find out what they actually found.
Thank you for having me on my third attempt to try and present the recovery trial. Sorry for anyone who's aware that I missed my previous 2 slots. My name is Jo. I'm an ST5 trainee in anaesthetics and ITU, and I'm currently based in Glenfield. And I am presenting 2 years of the recovery trial. As you all know, it's a big study, lots of arms to it, so it's either very complicated or very simple, depending on which way you look at it. So what I'm going to try and do is to try and summarize the study protocol and summarize the results so far. There have been over sort of 10 arms that have had results, and I'm just going to summarize the results from dexamethasone because that was the first landmark result, and then also a little bit about baricitinib because that's the most recent positive result that we've had. I'm going to try and talk about some limitations and critically appraise the evidence that it's given us as part of my own ongoing learning of how best to appraise any evidence that is presented to me. And then I'll go over what future results we're waiting for and what is actually still going on with the recovery trial. So first of all, the study protocol. The headline is that it is a multi-center, open-label, randomized, adaptive clinical trial. Multi-center is self-explanatory. It's involved 177 sites across the UK. Open label being that everyone knows what the patient is receiving. There's no attempt to blind things. Randomized being that patients are randomized to either usual care or a treatment arm, and I'll go into that in a bit more detail. And the adaptive clinical trial, I've got another slide to explain that is on the next. So when the trial first started in March 2020, it was just UK based. Any NHS trust could sign up amongst the other trials that were going on at the time. And then in February 2021, it also involved 17 sites across Africa and Asia, about 5 or 6 countries. And it recruited over 1,000 patients from there as well. So adaptive clinical trial, but whenever you read any sort of BBC or layman's articles about the recovery trial, they make a big deal about this sort of really innovative adaptive clinical trial that they've used to try and evaluate all these different treatment arms. But actually, adaptive clinical trial, the method was approved by the FDA in 2010, and they issued guidance on how to conduct an adaptive clinical trial. And essentially what it involves is that the treatment arms are set out at the beginning of the trial, but then there are predetermined time intervals where they look at the results from the different arms, and instead of saying, okay, that's the end of the trial, they will then change the treatment arm, either changing the doses or removing or adding treatment arms, which we've most commonly seen during the recovery trial. So it's really a sort of a dynamic clinical trial process instead of the sort of classical randomized control trial where you try one against the other, stop at 6 months. So the benefits of using an adaptive clinical trial is that it allows rapid evaluation of different therapies. In terms of the recovery trial, that predetermined schedule is 28 days. So arguably every 28 days you had a set of results to look at, so you could then decide whether to keep or get rid of that treatment arm. And it also allows different arms of therapy to be looked at, either in combination or on their own, which just gives you a lot of wealth of information about whether different treatment arms work synergistically together, whether they might cancel each other out. But then the downside of using such design is that you then only look at short-term outcomes. For something like COVID, where you're arguably either dead or alive or discharged at the end of 28 days, it worked quite well. I think when the adaptive clinical trial was first implemented, it was used for a lot of cancer type trials, and therefore they missed out looking at things like cancer recurrence. So that's a downside to using a trial like this. Back to the recovery trial specifically. So the eligibility criteria to be in the recovery trial is this moment you step into hospital with either confirmed or suspected COVID-19. Now, at the beginning, people were tested when there were tests in the hospital, whereas towards the end of the trial, everyone who walked into the hospital had a COVID swab shoved up their nose before they were even asked what their problem was. So that is a variation over the past 2 years. Initially, only adults were recruited, and then later on, children were included all the way down to the age of 2, especially for dexamethasone. And as I've mentioned, patients are either randomized to usual care, whatever usual care at the time is, and as we all know, that has changed wildly over the last 2 years, or usual care plus one or more of the treatment arms, whichever treatment arms are under study at the time of randomization are also which ones are available at said hospital. Some hospitals will only have dexamethasone, some of them will have all of the treatment arms. So which one you're randomized to really depends on what hospital you're in. Another thing that the recovery trial group prided themselves was of how they managed to streamline the whole process and make it very accessible to anyone to get involved in the research trial. So everything was online and as simplified as possible. So consent, randomization, everything is online. You click start, you go through the progress bar, and you end up at the end with a page saying your patient is going to have baricitinib, and that's it. You've got an online consent form that is recruited. Exclusion criteria is if the patient has any contraindication or an existing indication for the treatment arm. So anyone who is already on dexamethasone or prednisolone for any reason would be excluded from the steroid arm, but they can still be randomized for the other treatment arms that are available at the time. So what that ends up with is a really broad inclusion criteria to get as many numbers in as possible, which also allows for subgroup analysis later on. The outcomes for all the treatment arms are recorded, like I mentioned before, at 28 days. So are they still alive at 28 days? Have they gone home at 28 days? Have they needed mechanical ventilation, and have they needed renal replacement therapy? Were their primary outcome, well, the death was the primary outcome, and then discharge, ventilation, and renal replacement therapy was the outcome. I'm sure it was to get it through ethics. Every 2 weeks, they submit all of their data unblinded to an independent data monitoring committee, and that's really a safety mechanism to make sure if there's any gross discrepancies in mortality between the treatment arms that the trial can be stopped early, either in favour of one arm or the other. In the study protocol, there is a plan to follow up all patients at 6 months, either by telephone or clinic, but I couldn't find any of the results from this follow-up so far. I'm sure it will. So the treatment arms, and this is going to remind us about how things looked like 2 years ago. This whole presentation is a journey through COVID, through the eyes of the recovery trial. So back in March 2020, these were the treatment arms, and some of these words we don't even recognise anymore. So we started with dexamethasone, the infamous hydroxychloroquine, azithromycin, convalescent plasma, all these that no one talks about anymore because they've been disproved to be of benefit. Tocilizumab and serlimumab were also in the first treatment arms, and we all recognise that dexamethasone and tocilizumab and serlimumab are the drugs that have remained until today. And since then, we've also completed treatment trials in colchicine, aspirin, ronapreve, and baricitinib, of which ronapreve and baricitinib have joined the club of showing survival benefits. That is basically the summary. Everything now is going to be more detailed. So going back to dexamethasone, which was the first landmark positive result from the recovery trial, which came out, I think, preprint June 2020, so 3 months after the trial even started, and I think it was formally published in July 2020. And the treatment arm in the dexamethasone was 10 days of dexamethasone, 6 milligrams. So in that original trial, and back then there were huge numbers of patients. There were plenty to randomize. Over 4,000 had usual care and 2,000 had dexamethasone, and that was the ratio that the protocol randomized to because there were so many arms at that time. A reminder that in amongst all of this was a lot of noise, so all of these other arms were going on. When Desivir came in, I think that might be the remap cap trial, I remember, that was introduced in May 2020. The other thing that was going on at this time was that we went from either giving 15 litres non-rebreathe to everyone to ventilating everyone, and I think halfway through the recruitment period, people started creeping. So this is the noise that is going on in amongst the usual care versus dexamethasone. These are a boiled down version of the patient demographics. So at that point in time, the mean age of patients that were admitted was 66. Most of them were men. Over half of them had a major comorbidity, and looking at the two groups that are randomized, they were pretty similar. Of note, at that time, 16% of patients who were randomized were already ventilated or on ECMO. 60% of them were on normal oxygen, and 24% were receiving no oxygen or no ventilatory support. Negligible amounts were on CPAP or NIV in the data that was given. I think towards the end of the randomization period, there were people who were starting to go on NIV/CPAP. And of note, people who were receiving ventilation were 10 years younger on average, which is to be expected. So these are the results for the primary outcome, which is all-cause 28-day mortality. And it's quite a busy slide, lots of numbers, but the headline figure, which was sold at the time, is the second row of figures, which is in those receiving mechanical ventilation, the adjusted rate ratio of death at 28 days is 0.64 in the death group. Or if you want to look at it a different way, if you were mechanically ventilated at 28 days, 41% of the patients died, whereas if you had dexamethasone, 29% of the patients died. So that is certainly a statistically significant decrease in death at 28 days. And across all the groups, there is an overall decrease in mortality. But then of note, at the bottom row, in people who were not receiving oxygen, no mechanical ventilation, there is a non-significant increase towards death. So there was a potential harm in giving dexamethasone to those people who were on no oxygen. And these were the survival curves, which I think triggered everyone into thinking that dexamethasone is a wonder drug and it is made a big difference. Top right-hand corner is the mortality curve or a Kaplan-Meier curve for dexamethasone in those who were mechanically ventilated, and you can see that those who had usual care had a higher death rate than dexamethasone at that time. That difference becomes greater towards 28 days. What we don't know, of course, is what happens after 28. Some sort of secondary outcomes at 28 days, so there was less death, but there was also a slight increase in discharge in patients who had received dexamethasone. And of those who weren't mechanically ventilated at the beginning of randomization, there was also a small decrease in the risk of you then becoming ventilated. So 6.2% of the patients who weren't ventilated needed then to be ventilated later versus 8% if you hadn't had dexamethasone. In terms of adverse reactions to what the downsides of giving dexamethasone, there were 4 reports in amongst 2,000 people of people having hyperglycemia, GI hemorrhage, and psychosis, and these are very well-known side effects of dexamethasone. Of course, these are the reports these are the adverse reactions that were reported. I suspect there were probably many more episodes of people going on sliding scales and coffee ground vomit and brown stuff coming off NGs that weren't reported. So looking at the survival curves, looking at the initial data, in June 2020, just after the preprint, the chief medical officers issued a recommendation across the NHS that anyone requiring oxygen or mechanical ventilatory support should receive dexamethasone as per the trial protocol, with a recommendation against anyone who is not on oxygen because of that potential harm. So that changed practice almost virtually overnight, within 3 months of starting a clinical trial. So limitations to the data that we have so far on dexamethasone, a couple of things I've already touched upon. Number one is that it is an unblinded study, although arguably at the beginning no one knew what they were doing. There was complete equipoise in what we were doing, so it probably made very little difference. And as I've mentioned, the care in the usual arm was non-standardized. In the beginning of the pandemic, people were doing wildly different things: fluid research, non-fluid research, thalidomide, proning, not proning. So what people were receiving in the usual or the non-usual arm was just so vastly different. You've got very heterogeneously different patient groups. And because so many different trial arms were being tried at the same time, and all of those people who were randomized to dexamethasone may or may not be receiving the different treatments as well, means that the chance of a type 1 error or a false positive error is increased. And because of the sort of prospective nature of the trial, there was no formal statistical calculation on the power of the study, so how many people they would need to recruit to actually detect true difference. So that is something to bear in mind with this type of study in general. And I think this is probably the most important one, in that the data stops at 28 days. And maybe I didn't look hard enough, but I couldn't find any data for beyond 28 days. And certainly from my experience, lots of people, especially those that are ventilated, survived beyond 28 days and then maybe died of multi-organ failure a bit later on, 30, 40, 50 days, in which case is that benefit of survival at 28 days, if that doesn't translate 40, 50 days down the line, then actually how much benefit are we giving to the patient overall? And again, this is an overall criticism of this type of design study and the decision to stop the data at 12 or to analyze the data at 12. And this is a statistical quirk that I reminded myself, in that the headline of dexamethasone is that it reduces deaths by 1/3 in the sickest of patients, which sounds amazing, and I can't sort of underplay how important dexamethasone has been. It has been, but we do need to remind ourselves that headline of 1/3 is a rate ratio decrease of 0.64, which is the proportion of people who died divided by the proportion of people who didn't die. So, the proportion of people who died having dexamethasone divided by the proportion of people who died in the usual arm. Whereas the absolute risk reduction, so if you minus one from the other, is actually 12%, which means that your number needed to treat is 8. So you need to give 8 people dexamethasone when they're on a ventilator to prevent 1 death at 28 days, which is still impressive. but that's a reminder to myself to not be sold by the one line that makes it to the top of the. Keeping along 2 years on, this is a diagram that was on the recovery website that basically summarizes all the different arms. So from the beginning on the left, when the trial first started, to on the right, with all the results of the treatments that we've had so far. Like I've already mentioned, dexamethasone, tocilizumab, ronapreve, and baricitinib are the ones that have come out positive, and all the other ones have now been proved to not be beneficial, at least in the recovery trial. So aspirin, colchicine, hydroxychloroquine, convalescent plasma, they have all been dismissed as ongoing COVID treatment. We're going to talk briefly through baricitinib, just because it's the most recent positive one that we have, and also the data that is presented for baricitinib also just tells us how far we've come along in the treatment of COVID. So the data comes from a preprint at the beginning of March 2022, so just a few weeks ago. I'm less familiar with baricitinib. It is an anti-inflammatory drug which has been used to treat rheumatoid arthritis. So for baricitinib, 8,000 patients were recruited and randomized between baricitinib and usual care. And usual care now involves everything that we know: dexamethasone, tocilizumab, ronapreve if they haven't had a vaccine if they've had a vaccine, and CPAP until they need intubating. So usual care now has drastically changed from when dexamethasone was first introduced. So exclusion criteria: people were recruited all the way down to 2, and people who are significantly immunocompromised, so renal failure, neutropenia, active TB were excluded. Pregnant and breastfeeding people were excluded. And to be aware, at that time, as well as the usual care that I mentioned, colchicine, aspirin, these were the other treatment arms that were going on at the time. So this slide tells us how things have changed since the dexamethasone trials. The mean age is 58, so lower than at the beginning. 47% of all recruited patients had at least one comorbidity, again less than before, which might reflect the fact that we've had a younger population over the years because of vaccination and the unvaccinated population. And like I said, usual care is now steroids, tocilizumab, remdesivir, and ronapreve, and this is reflected in what the recruited patients had. 42% of the recruited people had had one vaccine. 60% of people were unvaccinated, which is probably quite reflective of what we were seeing, of who was coming in with COVID. And again, this the last statement there shows a change in how people were treated from a respiratory point of view. So most people were on normal oxygen, a quarter of them were on NIV, and small fractions of people ventilated, and even 5% of people not on oxygen at all. By this point, we were quite confident in treating people who didn't need oxygen out of hospital, and obviously keeping people on NIV for much longer, so the fraction of people who are mechanically ventilated is much lower than when the dexamethasone trial was going on. And these are the results, again, for the primary outcome, which is 28-day mortality. And the headline figure that was used for baricitinib is an overall reduction in mortality from 14% to 12%, which gives us a rate ratio of 4.87. I've got a couple of figures in bold there, which is the confidence interval for the change in mortality in those who are ventilated and those who are on no respiratory support at all, where it spans 1, which means that there is a chance that actually there's no difference made. And overall, you might not remember the figures from dexamethasone, but all of these mortality figures in all of the columns are lower than the dexamethasone group. So over the 2 years, the overall mortality in all groups COVID has decreased. For the secondary outcomes, there is a trend in improvement in discharge alive at 28 days, small differences. And of those not mechanically ventilated, there is a trend towards less people needing ventilation. Compared to dexamethasone, there's more reports of serious adverse events with baricitinib. including serious non-COVID infections, so secondary infections, bowel perforation and pulmonary embolism, and these were reported adverse reactions, which meant the clinicians involved were sufficiently convinced that these were related to baricitinib. And there's also an increased reporting of cardiac arrhythmias, 3.1% versus 2.3% in those not receiving baricitinib. So again, this is me reminding me of myself of statistics. The headline is that baricitinib reduces death by 1/8, about 1/8. That's what it says in the word, about 1/8. Which comes from the all-cause mortality rate ratio of 0.87, so there's a 13% rate reduction, which is about 1/8. However, as I highlighted, there was a really wide confidence interval for the mechanically ventilated and the non-supported groups, and I think part of that comes from the fact that they are very, very small patient numbers, which makes it very difficult to detect the real difference. So while the death is reduced by 13% or 1/8, the absolute risk reduction here is actually 2%, just because the death rate is now so much lower, and the number needed to treat, according to my maths, is 50. So the magnitude of difference made by baricitinib compared to dexamethasone is arguably much smaller. Like I said, because mortality is now so much lower, in order to get a higher powered study, it's much more difficult to get a sufficiently powered study to detect real difference. So looking towards the future for the recovery trial, these are the treatment arms that have, I think, completed recruiting, but we're still waiting for results for dimethyl fumarate. What that is, I think. And the treatment arms for PIMS-TS, which is the inflammatory syndrome seen in children, for methylpred, IVIG, tocilizumab, and anakinra. So these will be out. And these are the current trial arms. So there's a trial between high-dose dexamethasone, I think I remember correctly, like 20 milligrams for 5 days or something like that, versus normal dose. So this one will be difficult to argue against if it's assuming that they're not blinding this study, it will be much more difficult to argue equipoise. So the results from that will have to be taken much more carefully. So empagliflozin, I can't say it, and then the antivirals, which have already been approved for use in early COVID, but the recovery is looking at their use in hospitalized patients, so patients who, by definition, have more severe disease. And they've also started studying the effect of different treatments in influenza, because there is a prediction, and we can see already that there's now more influenza coming into hospital because of the reduced transmission last 2 years. So take-home messages from the recovery trial in general, these basically things that I've learned, is the sort of increased light put on the use of adaptive trial designs to look at new diseases. So COVID came out of nowhere, and in order to really rapidly look at different treatments, an adaptive trial design was used, and I think that was the first major trial where it really made the headlines, and everyone learned how to recruit and learn how to sort of interpret results from an adaptive trial design. But we have to be aware of the limitations of the short follow-up time. So 28 days was chosen at the beginning of the trial because that was the natural history of COVID at that time. At 28 days, you could really tell whether people were going to do well or not, whereas arguably towards the end of COVID, at least from my small amount of experience, people were easily surviving 28 days on a ventilator, plus or minus a tracheostomy, but then they died 50 days down the line. So the natural course of history of COVID has changed, and that limitation has to be factored in when we're interpreting more new and more up-to-date data. And as I said, because so many different arms are being tried, the groups that you're comparing to have lots of confounding factors, and that has to be borne in mind as well. And using the difference between baricitinib and dexamethasone, like I said, baricitinib has this headline figure of 1/8. The absolute reduction is actually 2%. So actually, as COVID becomes hopefully milder and the vaccine is in place, different treatments, when we're getting mortality benefit, we're actually talking about marginal gains. We're talking about 2%, 1% increases. So that is something else to bear in mind. And we are awaiting data for that 6-month follow-up that the study protocol has promised us. These are my references. Basically, the study protocol and the papers from the 2 drugs. Thank you very much. Questions and thoughts? Don't make the questions too difficult.
Thanks, Jo. That's really well presented. Yeah, like you say, we've all kind of lived it and gave a lot of those drugs. Many people.
Yeah.
Yeah, you're right. It was a kind of story through the pandemic, wasn't it? Of which when we did stuff and why, and then when we stopped doing those things because it didn't actually work. Kind of weird.
Remdesivir was the one for me because I skipped the first wave, and then remdesivir was like, and then suddenly it disappeared, and I didn't really know why, but I didn't ask questions at the time. I was like, oh well, do what that's on. But that was just from when I was standing.
I was going to ask whether, well, what I normally ask is, does it affect your practice? But it's kind of feels like a silly question right now.
Yeah, well, it's affected my ongoing understanding of how to adapt our practices.
Fair. I quite like the recovery trial because I quite like the adaptive trial design of it. Which is quite interesting, and it keeps changing and it keeps adding drugs without there being a big hoo-ha about it, and you just kind of get on with it, which is quite nice as the evidence changes. So
when I was reading about this, I learned about the remap crap. I think when I was in Boston, they were recruiting to the remap trial. I think that was going on for longer. I think that's an adaptive one as well. But I think the difference with recovery is that everyone then knew about it.
Yeah.
Which also means that people think about it more. I think when I first read about it, I thought it was great as well. But actually, the more I thought about it, the more I realised that actually, as time goes on, there are more problems with it, which I talked about at the end of the study. And I don't know if there's scope to change, for example, like the 28 mortality. I do think that there's limited value in looking at 28-day mortality on its own. Well, we can't now, but it's something to bear in mind.
Yeah, definitely. It's the same with the government looking at COVID death within 20. Yeah, it's what the government are doing, isn't it? You're like, well, it's not actually long enough a lot of the time. Anyway. Anybody else got any questions or comments? Gonna guess no. If you stop sharing your screen a second, Jo. I'm going to share this one so that if people would like to give feedback on either of our 2 presentations today, that would be great. I will also put the link in the chat in a second when I can, just in case that's easier. There we go. So yeah, thanks Emily, thanks Jo for your time and your presentations. Excellent.